Okay, I think that we'll all agree that there's a lot of complexities in exchanging healthcare information amongst our organizations, but then if we add into that trying to integrate with the foster care system or correctional facilities, that adds a whole new layer of complexity. So here to explore that further, we have Dr. Jeanette Sheed, medical consultant with the Michigan Department of Health and Human Services. We also have Lori Kisaw, Director of Nursing, and Liz Solomon, Health Informatics Specialists, both from the Michigan Department of Corrections. Welcome, ladies.
All right, this is really loud, I've discovered when I just came by accidentally. So, my name is Jeanette Scheid. It's a pleasure to be a part of this conference and to engage in a conversation with you about information management and needs to support. Is this going to come up? Ah, there it is. Information to support the healthcare and meeting the healthcare needs of children in child welfare. During this presentation, I'm going to talk a little bit about some of the background on child welfare systems generally and introduce you to our child welfare case management systems known as Michigan Statewide Automated Child Welfare Information Systems, or MiSACWIS. And we're going to talk a little bit about the current strategies for obtaining and managing health information within MiSACWIS. I'm hoping that that information, by the time we finish our conversations, will generate discussion about effective ways of using health information technologies, including networks and exchanges, to improve the capacity of child welfare professionals to support children and families. So I wanted to start with a few numbers. At any given time, there are approximately 13,000 children and adolescents in foster care, but the information management needs actually start with reports of suspected abuse or neglect. It's common for about 15,000 suspected abuse neglect complaints to come in each month, of which about 8,000 are assigned for investigation, and 2,000 to 3,000 victims of abuse or neglect are substantiated or confirmed. I'm going to be focusing on the 400 to 500 children each month who come into foster care, because once placed in foster care, MDHHS assumes responsibility for working with all of its partners, including parents, foster parents, and healthcare providers and partners, to ensure that healthcare needs of children are met. I also wanted to make you aware of the three key and interconnected goals of the child welfare systems. The first is permanency, which means working to find a permanent home for each child, whether this means supporting the successful reunification with a family of origin, finding an adoptive placement when reunification is not possible, and helping any youth who need it to transfer successfully into young adulthood. In the short term, it also means working to support foster parents to limit the amount of transfers from one foster home to another, which is really important for the well-being of children. Safety means recognizing the risk factors and preventing occurrence of maltreatment whenever possible, minimizing the trauma to kids and families during separation when that is necessary, and supporting children and foster caregivers to reduce and then hopefully eliminate additional episodes of maltreatment when children are in care. It also means attending to any of the risk factors or issues that might put a youngster at further likelihood of harm. And finally, well-being means working with children, caregivers, and providers throughout the systems of care to meet health needs, developmental and behavioral health, but also to support healthy growth and development across the spheres of a child's environment and to enhance safety and permanency. So there are a number of benchmarks that the state uses to measure progress towards supporting the well-being of children. This is not a comprehensive list, but it is key to the discussions around health. The first, which I don't have listed here, is actually ensuring timely opening of the foster care department ward Medicaid, which is one key act that has to happen for access to health services once children come into foster care. But it is also ensuring that each child obtains a routine, a comprehensive health exam within 30 days of coming into foster care entry, and this also means, from a health information standpoint, ensuring that providers completing those exams have some of the information that they have to do a good job of that activity. Ensuring that each child obtains routine health exams recommended by the American Academy of Pediatrics based on evidence about what supports the healthy growth and development of youngsters. Ensuring that at any time a child presents with some acute medical problem or behavioral health problem, that is examined and that follow-up occurs appropriately. Ensuring that dental exams occur on a timely basis. At this point, the state standard is within 90 days of foster care entry, unless there is evidence of an exam within the 6 months prior to foster care entry. And then finally, a section related to monitoring consent, which is one key quality indicator and best practice when it comes to psychotropic medications, and also monitoring the patterns of psychotropic medication use. There's pretty abundant data that children in the foster care system are taking more psychotropic medications, including more complicated regimens, higher doses, than are their counterpart youth who are served by Medicaid but not in the child welfare system. I should also note that each state is required to develop and implement and report on a plan to address these issues and report back to the federal DHHS on a regular basis. So when it comes to gathering these information, caseworkers have to work with multiple sources as they begin to gather information at the beginning of the time of an abuse, neglect, suspected complaint, and through the course of a child welfare case. From the very first contacts until the case is closed, families, children, parents, families, and caregivers are key sources for a lot of information, including health information. And caseworkers must then follow up to obtain the appropriate consent, to obtain healthcare information so that it can be integrated into treatment planning for that youth, and then transmit that information to new providers to ensure care coordination. It is best practice for child welfare personnel to come to health-related appointments, but the truth is that their schedules are really busy. They have court appointments, they have visitation, they have a number of children on their caseload, so it is not always possible for them to be there. Under those circumstances, they ask foster parents to provide that information, but they also reach out to health providers to get information such as the visit summaries that are now often provided at the end of each appointment, or more comprehensive documentation that happens after an appointment. The other complexity is that sometimes foster care workers do not find out about an appointment until after the fact. So they are sometimes sort of reaching out after an event has happened to try to gather the data from that health event or appointment. The DHHS has expanded access to some additional tools and databases, including the Michigan Care Improvement Registry, or MICR, and Care Connect 360, which is one of the software systems that gathers and coordinates in a software system the health information data warehouse information. Caseworkers have access to these sources, and they can use them as a starting step to engage children and families in getting more detailed information that's not available in Medicaid claims. All right. The other thing is that MySACWIS is used for a number of different purposes, and for the most part, information that comes into MySACWIS and is disseminated out has to be hand entered. So the user groups include tracking the progress of abuse and neglect investigations, documenting legal status, identifying and managing placements, documenting permanency goals and progress towards those goals, and tracking health and educational needs for children in our system. For health-related concerns, the chief data enterers are the direct child welfare staff that includes CPS, foster care, and juvenile justice, but also their supervisors, and then also data management folks like the individuals from our psychotropic medication oversight unit who have access to that system, enter some data, and also at the state level, management level can look at the information in MySACWIS and use it to also develop and improve policy and practice. There are some other Well, I think I just didn't go right past. This is the problem that you have when you're tackling a number of things. So there are some other tools that caseworkers have. There is an entity called a book of business, and this is where the timelines for some key activities are kept to sort of help caseworkers keep on top of medical exams, dental exams, other key time points in a case. The information that comes into the health screens, which I'm going to get to in a minute, populate the medical passport and the health sections of the case planning documents. The medical passport is a legally mandated document in the state of Michigan. It's used for the health management and addressing the health needs of kids in foster care. The passport has information about the health history of the child, including their medical history, including history that occurred prior to coming into foster care, and updates with the services in hopefully real time as they occur. It's given to foster parents at the time of an initial placement, including if a child moves to a new placement, that new foster parent will get a copy of the passport. It's also provided to birth and legal parents on a quarterly basis, and it's provided to healthcare providers who are new to that child's case. The other place where some of the information from the health screens goes is into the service plans, both initial and updated service plans, which contain some of the healthcare needs and goals. The next several slides, including this one, will walk you through some of the health screens in MySACWIS. They're kind of screenshots. So the first thing is whenever somebody gets into the MySACWIS system, they can search for a child under name and other identifiers. When they find that child, they can click on a screen that will get them to this opening page. And this has a lot of the different aspects of case management, including the health history that takes them to the health screens. This is the main health screen into which information is entered and then used for other purposes. It includes health needs and diagnoses, appointments, medications, the child's medical history, the family medical history, provider information, and a screen where they can access the immunizations history from MICR and generate the medical passport. In the first tab that I have listed here, the staff enters known health or behavioral health diagnoses that they get from whatever sources they have been able to identify. This might be a family member, it might be a parent, it might actually be diagnostic information from documentation that they got from providers' offices. The appointment screen is for each of the appointments that a youngster participates in over the course of the time in foster care. The caseworkers or other staff enter this information, including the purpose of the appointment, the provider, the date of the appointment, and any additional information important to that activity, including the need for follow-up, which is one of the other benchmarks that we have to ensure that follow-up occurs when it is recommended. And this information can come from a variety of sources, including the person who accompanied the child to the appointment, which is most often the foster care parent. But it also might come from clinical documents such as the after-visit summary or more comprehensive health information that is forwarded by the provider or the office, and this usually must be done on request. Child welfare staff also enter medication data for youngsters. For general medications, such as medications to treat diabetes or asthma or infections, this is done by the caseworkers. They would have access to Care Connect 360 plus any information that came back from provider offices to help them track the medications that a youngster is taking and then follow up with information if they need it. For psychotropic medications, the unit that focuses on the monitoring of our psychotropic medication use in foster care are the individuals who enter this data. That group has direct access to the health services data warehouse. They use that as a starting step. They enter the information for medications when they first see a claim for a medication, but any updates need to come through communication with the caseworker. So ongoing management of psychotropic medications at this point is not an automated process. There is a screen where, whenever possible, caseworkers will work with children and families to gather health information about the youngster, so the child's own medical history. Again, Care Connect 360 can help with this, because once that child is within the system, the caseworker can check for chronic conditions, other health conditions, providers, et cetera, and they can use this as a starting point for gathering information from families and reaching out to healthcare providers for more detailed information. There is also a tab for family medical history. I'm not highlighting it here in part because that information is available to the caseworkers in the same way, but it does actually not populate in the child's medical passport in the same way that the child's own health history does. The last screen I'm going to talk about, skipping over the provider screen, which has basic provider information, is the tab where caseworkers would be able to look into to MICR and also take the steps needed to actually generate a report, which is the medical passport. I should say that the information in the passport then is directly dependent on the information that was hand entered by the child welfare worker and other staff during the time of the case. So this graphic kind of illustrates some of the ways in which information transfer happens. So MySACWIS has a window into MICR, so this information can be integrated into the sections in MySACWIS, such as populating sections of the medical passport, but the information from MICR is not held in MySACWIS per se. It's a window and a connection. Almost all of the other health information, and there is potentially a lot of it that comes from children and families, other caregivers, the healthcare providers, et cetera, and our databases, such as the Health Services Data Warehouse, actually needs to be gathered and then hand entered by caseware staff for that information to get into documents like the passport and documents like the initial and updated service plans, and to be available to other providers. So there's certainly a lot of challenges that we continue to face and try to work on. This includes the first thing, that caseworkers have to engage families to obtain some of this information during some of the most difficult moments in a family's life, around the time of a suspected abuse and neglect and removal of a child from a parent's care. Caseworkers also have to navigate multiple systems intended to preserve security and safety, which is appropriate, and privacy, but which are not well coordinated at this point. For example, a provider might have their own consent for release of information form and may not accept the consent for release of information form that MDHHS uses as its default setting, and that may be the form that the caseworker would have engaged the parent to sort of complete and sign, and it may not be an acceptable form. Caseworkers also have to navigate these other systems that don't understand the child welfare system that well. They may not be aware of child welfare policy. They may not be understanding our needs related to care coordination, the roles of the different people involved in the system. And as is true of almost all of our health systems at this point, information is just sometimes not available in a timely manner. It doesn't matter whether we're talking the foster care system or not. And finally, caseworkers have to hand enter almost all of the information. It's time consuming, but it also might require them to translate, prioritize, and summarize, which can be sometimes challenging for them. And all of this has to be done in order for that information to be available to the rest of the system and the partners in child welfare. So in summary, before we move on to the challenges in the Department of Corrections, I think everybody wants to find ways to meet the healthcare needs of kids in foster care, and we recognize that that includes gathering and disseminating healthcare information. But it's also critical to develop a system that supports privacy and security in a very complex system with a number of users. We also need to put tools into the hands of caseworkers that will help them do this work and support the health and well-being of kids and families. And this includes trying to work on ways to limit the need for user entry, because this is not only going to be more efficient from the casework standpoint, but is also likely to improve the quality of the information that comes in, and then the quality that goes out to our partners. So we look forward to continuing to work with all of the systems and all of the partners that we can to make some of these issues happen better. Thanks so much for your attention.
Good morning. Thank you for having us today. My name is Liz Solomon. I'm with the Michigan Department of Corrections, and I'm the Health Informatics Specialist. And this is,
I'm Lori Kiss. Is this on? Hello? I'm Lori Kissa. I'm one of the directors of nursing with the Michigan Department of Corrections.
so Lori and I today are going to just give you an overview of the Department of Corrections, how health care is provided to the prisoners, how information is exchanged throughout the system and collected and exchanged throughout the system, from intake all the way until the transfer to different facilities and on discharge from the prison system. So we'll start off with the Michigan Department of Corrections mission, vision, and value statement. The MDOC's mission is that we create a safe Michigan by holding offenders accountable while promoting their success. Our vision is that we will continue to be a leader in corrections by transforming lives through innovation and dedication. And the values that we hold is integrity, teamwork, leadership, excellence, respect, and loyalty.
Did you already have it? Okay. So I'd like to give you a little overview of what we deal with in the Department of Corrections. There are actually 29 prisons, and we service roughly 39,000 patients or prisoners. We call them patients. So we look at it as being one practice with 29 locations. We share medical record throughout those locations, and the services that we provide. Well, let me take a step back. Let's think of each of those locations like a small community, roughly 1,000, maybe up to 1,500. We have some prisons with a couple thousand prisoners. And there's things like postal services. They're provided with meals. There's a meal service. They have a store that they can purchase from. They have educational opportunities. They have vocational opportunities, as well as the things that are provided for health services, which are outpatient services in our ambulatory clinics. Those are available generally 5 days a week, as well as nurses staff them 24 hours a day. We have inpatient care that's at Duane Waters Hospital in Jackson, as well as we have other inpatient services throughout community hospitals that we house prisoners at. There's emergency care both at the local emergency rooms and at our Duane Waters Health Center. Offsite services, which are local services with specialists. We have mental health services. Those are on-site and via telehealth. Dental services. Telemedicine. We have been using telemedicine for 10 years or better. And mostly it is for specialty visits, infectious disease, nephrology, dietary, dermatology. We also do psychiatric visits that way. We have a hard time finding psychiatrists to come into the prison, so we've decided to utilize that, which works very well. As well as we do some primary care visits that way as well. We have optometry services, therapeutic diet services. So anything that you would cast a net in the local community, pretty much we have.
So our health record, our health information process is an integrated record, which it includes dental, mental health, and healthcare services, and any off-site healthcare services that are provided. So it's one health record. As Lori said, as they come into the prison system on intake, we gather information, and then that record is both dual. It's in paper and electronic form. That is not ideal. It's not where we want to be, and we're moving away from that or towards a new goal. But right now, they do generate a paper record and an electronic record. Most of the paper record includes things like medication administration records, consents, and a few other forms that are not integrated into our health record. They maintain that record continues on throughout their incarceration. So as you can imagine, if someone is in there for life, we have volumes of paper records that might be 6 volumes this high and it's very difficult to manage. And then we also have the electronic health record, and we are now getting to a point where some of our offenders who have mental illness and healthcare issues, we are getting space issues for those very complicated offenders because we have a lot of information that is entered into the record. We are moving to a new electronic health record here in December, which we're very excited about. It is called a Correctional Offender Management System. It is not only just a health record, but it will also communicate with all of our legacy systems that the offender, we manage the offender on the correctional side, and it will also help us to build better interfaces to the community, to our pharmacy vendors, our lab vendors, and then we will be going paperless, which we're extremely excited about. We also have portals access to many community hospitals, and our goal is to improve and increase exchanges. And then we have a PACS system, which holds all of our diagnostic x-rays.
So we get prisoners every day at our reception centers. The main center is in Jackson. We also have Women's Huron Valley that receives prisoners, Marquette Branch Prison that receives prisoners, and Detroit Reentry also receives prisoners. So they're coming to us every day from jails or from courtrooms, and we receive them. Oftentimes they're very poor historians. They aren't certain what medication they're really supposed to be taking, what their diagnoses are, so it becomes quite a little sleuthing project for us to fill in the blanks. So all counties are required to, if they're coming from the county, to send us with what information that they know about the prisoner, which includes medications, their diagnosis, any treatments that they maybe received while they were in the jail system, TB testing information, and maybe that they had gone to a local hospital. Once we receive them, we take that information along with interviewing the prisoner and doing physical exam and piece together information by getting releases signed to be able to obtain information from local hospitals, specialists, or anywhere else that the patient has said that they received care. It can be quite a lengthy and paper-intense process. And we receive that information, we retain it in our paper health record. As Liz said earlier, we're moving in December to an entire electronic process, which will include that information being scanned into our health record, which we're really excited about. This is an example of the limited information that we get from say, a jail type system. This patient, I believe, was a female. We know that what the TB skin test results are, there were no allergies. Looks like they were on some antibiotics. So we get very limited information.
So as the prisoner transfers to another facility after intake, we have health information managers at each facility within the Department of Corrections. That staff are responsible for managing and maintaining that health record, and they will process any release of information requests, whether it's a prisoner request or an outside request, continuum of care request, and anything that may be internal for the MDOC. They also will continue to reach out to outside sources. If they're going to an off-site specialty clinic, they will request that information from the outside sources or access a portal if it's something that we have access to. They get a lot of requests. It's a very busy place. Their challenges are that not all information is in the electronic record, but it's also in the paper record. There's many different sources, so trying to retrieve that information, it can be quite a challenge.
So something that we call intra-institutional transfers occurs nearly every day. Prisoners don't stay at the same prison their entire sentence. They transfer about once. One, it's a security reason. We don't want them to stay forever at one place. They get to know it too well, get to know staff too well, and that's a security issue. Secondly, their needs might change. They might have programming or educational needs. They might have medical needs that aren't able to be met at the current prison that they're at, because not all prisons are equal. There are different things that occur or are available at various prisons. We have a grid that we use to transfer people. So what happens is if a prisoner is currently at prison A and they're scheduled to transfer, say on Thursday, tomorrow, somebody at the prison, usually a nurse, will do a clearance to see what needs they have and can those needs be met at the next prison. Once they get to the next prison, they are seen by a nurse, screened in, making sure that their needs still can be met there, making sure they have their medications available, and that appointments that are upcoming are scheduled with the various things, perhaps a medical provider, could be a dentist, could be a mental health practitioner. So we make sure we keep close track of where people go and make sure their needs can be met wherever they're going to. And again, it's one record, so it's shared amongst the various prisons. So Liz spoke about specialist, and I touched upon specialist. We can't provide every single thing that this prisoner might need at the prison. So we know that they may need to be going out into a community and seeking some specialty visits in that community. So we use a utilization management process to do that. The medical provider will put in a request, an electronic request that is sent electronically to our team. The team reviews that request. I kind of look at it as the medical providers pleading their case. They're trying to make the statement of why that patient needs to go somewhere. They also attach any subsequent documentation, maybe from a local hospital or diagnostic testing from a lab or something like that, to be able to plead the case. If it gets approved, our offsite schedulers at each prison go ahead and schedule that appointment in the local community, or maybe even at our Duane Waters Health Center. We have some specialty services that are available there, and they might schedule it there. If it's not approved, it's usually given an alternate treatment plan, which means the utilization team makes a suggestion to the medical provider of something else that might be able to be tried at the prison setting in lieu of maybe an offsite. So this information is shared with the offsite specialist, and the offsite specialist then it shares information back, which either goes electronically into our record or we put it in the paper record. Well, so we know that 90% of our clientele is going to go back into the communities that you live in. So we start preparing them for discharge the minute they come into our system. Keep in mind, many of these people have not had great care while out in the community. Many have not had any care, whether it's dental care, medical care, mental health care. So we start with that, and we get them the services that they need so that when they come back to the community, they're hopefully they're better educated about themselves and their needs. They're not as big of a burden on the community, and that they may be able to become, hold a job as long as they're taking their medications and have services available to them in the community that they need. Some examples of linkages that we use is we work with federally qualified health centers. Right now we're using Kent County, Macomb County, and Berrien County. So any of those counties that prisoners are paroling to, if they don't have other abilities to connect with services, we look at FQHCs to try to connect them. We have VA services. We have a robust VA unit at Saginaw Correctional Facility, and so we try to look ahead at people who are paroling and maybe they've been veterans, and we try ahead of time to house them maybe a year or so ahead of time at the Saginaw Correctional Facility so they can link with VA services and pull from those resources. We have a Medicaid application process that we use to make sure that's linked up. Unified, we use their services for HIV prisoners who are paroling into the community to make sure that they have everything set up before they leave us so that they can get those services that they need. We help to find durable medical equipment in the community. We provide them copies of their health record. A dream of ours is to have a patient portal, so that will be nice, perhaps.
So we also have medical social workers that work on those more difficult, challenging cases. They will work on locating the durable medical equipment for them so that they have that on release. They maintain a list of health centers that accept Medicaid. They apply for Social Security Administration for those that will qualify. They contact and schedule initial and medical appointments, and those that are in high-need cases. Maybe they need off-site services, or they're in treatment for something and they need to continue that on as they leave the prison system. We also work with nursing homes and placement shelters and places that we know that can take prisoners, or we're willing to take prisoners as they leave our system. Health information, after they're paroled and discharged or deceased from the prison system, we have a health informatics department that deals with all of the release of information on those type of offenders, inactive offenders, and they get about 500 requests a month for information. So a lot of information is being exchanged, and they have the challenge of retrieving the paper record, trying to find the information, looking for it in the electronic record. And so they have a lot of different challenges. They also do prisoner request, off-site, any other requests that's off-site, subpoenas, court orders, continuation of care, and disability request. Our challenges in our electronic health record, or our health record process, obviously, is that we have both paper and electronic. Some of that is just data storage and the volume that we have for each offender to scan it all in. When we first started with our electronic health record, it was like in 2003, and we didn't have storage space for electronic, was very costly. And our system that we currently have in the is not able to maintain that data, so we have to keep two systems. Consents for release, just like with foster care, we have the same issues, not the right form. Maybe the prisoner doesn't want to sign it because they don't understand what it's for, who it's going to. Description of requests, we have a lot of challenges because we have a lot of information. I think a lot of people don't understand. We get a lot of requests, I want the whole chart. Well, they don't understand that that's 5,000 pages. And so we have a lot of challenges, a lot of rework of sending it back and forth, clarifying the request, and then obviously that affects the timeliness of the request and gives us more challenges to meet those deadlines that we have. Our goal as we move into our new electronic health record, we're very excited about it. It is going to help us to go paperless. As I said before, to build some interfaces, and hopefully in the future build some more a patient portal and some information exchanges that we can get this information out there as quickly as possible. Thank you.
I think we have some time for questions if anyone has questions.
My question is regards to parental consent for foster children. Is that a requirement, and what do you do if the parent doesn't want to give consent access to medical records?
Is this on? Okay. Parental consent for release of information is not, I mean, it varies a little bit depending on the legal status of the youngster, and it depends on the circumstances in the case. So, for example, it is under Michigan law, parents are actually required to provide contact information for all of the health care providers working with the youngster, and to provide that to foster parents. To provide that to foster care workers. It is then probably best practice to engage that parent, especially since a fair number of our youngsters are on the track to be reunified with their parents, to engage their parents in a discussion about the importance of coordinated care and the importance of getting consents for release of information to do that. As the kind of joint the fact that these youngsters are under court jurisdiction administered by the department, there are some capacities that the department has to get information under certain circumstances. That can be a hard sell to other providers because even if they recognize a youngster is in foster care and that the foster care worker, for example, could probably sign a consent for release of information to get the information, that medical office or entity may not feel comfortable with that, and so may not, without additional documentation, be willing to release those records. So there's lots of complications that are involved. If parents refuse, I believe that there are ways to go back to the court and discuss that. I think that part of the challenge is in the middle of a very busy time in a child and family's life to also pay attention to the importance of health information and providing consent for release of health information. I mean, I think that not understanding for mental health records, being concerned about stigma, trying to sort of maintain some level of control under circumstances when there is more involvement in somebody's life than they would like are all challenges in real time that have to be dealt with. And then assuming that you get that you sit down with a child and family and you fill out a piece of paper that's the DHS form and the parent says, yes, I'm willing to sign that, then you send it off to a provider and they say, we don't accept this form. So it's a complicated process.
Thank you very much, ladies. Appreciate your presentation today.